Have you heard about FDA-approved Vyvgart Hytrulo, efgartigimod alpha, and hyaluronidase QVFC for subcutaneous injection? Visit vyvgarthcp.com to discover clinical trial data and explore patient profiles. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco from the Neurology podcast, and I'm joined by Zsolt Illes to discuss this article published in Neurology, Mortality of the Danish nationwide AQP4 seropositive neuromyelitis optica spectrum disorder patient cohort. Zsolt is a professor in the Department of Neurology at Odense University Hospital in Denmark. Zsolt, thanks for coming on to the podcast with us.
Thank you very much, Justin. I'm very happy to be here.
Maybe we could start with some background on AQP4 positive NMOSD. How does it typically present, and how does the antibody testing typically fit into the diagnostic process?
Yes, aquaporin 4 seropositive NMOSD is caused by pathological autoantibodies, and these are generated against the main water channel of the central nervous system. Those are the aquaporin 4 water channels. And when these antibodies bind to aquaporin 4, which is actually located on astrocytes, then it activates the complement system and the astrocytes are destroyed. This is a very severe disease, and the most common symptoms are optic neuritis and myelitis. But the patients can have also brainstem symptoms, for example, area postrema syndrome, which can come with permanent hiccups. As you said, Justin, the antibody testing is therefore crucial in the diagnosis, and we use a specific assay, and this is called a cell-based assay, and in this assay we use actually transfectants, and we can detect the antibodies using the full aquaporin 4 protein on the surface of mammalian cells. This is a very sensitive assay, so that's where we are using this. And also the international diagnostic criteria require that we should use this assay.
Yeah, it does require a stepwise approach to the diagnosis. Those key clinical syndromes you discussed, optic neuritis, longitudinally extensive myelitis, and an area postrema, and then making sure the antibody testing is sent off to the right place. That cell-based assay is so important, otherwise we could miss some cases. And so you and your group used this nationwide cohort study identifying all patients who were AQP4 positive and fulfilling the diagnostic criteria in Denmark. And then you pulled all the relevant clinical data on these patients to determine the mortality associated with it. What did you find in this paper?
We examined the whole aquaporin 4 seropositive NMOSD population in Denmark, and we examined the mortality between 2008 and 2020. And we calculated life expectancies, and also the survival among the patients was compared to the general population, which was matched on sex, age, and also calendar year. And we found that the median age at death was 64 years in the aquaporin 4 seropositive NMOSD population. And we found that the median life expectancy for NMOSD was reduced by 19 years because the median age of death was 64 years in the NMOSD population compared with 83 years for the matched general population. So in fact, NMOSD patients lived 19 years shorter. And we also examined what's happening with the survival, and we found that it began to decline immediately following the clinical onset of the disease, and the cumulative probability of survival from disease onset was 90% for 5 years and 83 years for 10 years, which means that in 10 years about 17% of the NMOSD patients died. Accordingly, we found that there was a higher risk of death with a hazard ratio of 2.5 from the time of disease onset in the NMOSD population. So these are our main findings in this study.
So these are really stark numbers. What made you investigate this? What made you have that hunch that there was going to be this discrepancy.
And we were interested in the mortality because, in a way, mortality reflects also the severity of the disease. And of course, it has a direct implication on the treatment of this disease. We knew that NMOSD is a severe disease and the relapses are very severe. The problem was that in previous studies, there were problems with patient selection and methodological issues. So, for example, cohorts before reliable aquaporin 4 antibody assays may include seronegative cases or patients even with other diseases. So that's why we examined this Danish population-based study, and the patients were identified from multiple sources. We used our national registries and also medical reports, and this ensured accuracy. And it was also very important that we used the 2015 intentional criteria because cohorts before the 2015 definition included only patients with myelitis and optic neuritis and other core symptoms, for example, the area post-traumatic syndrome or other brainstem symptoms were missed. So we only included patients with aquaporin 4 seropositive NMOSD who fulfilled the 2015 criteria. So that was a very well-defined population. And we also published previously in Neurology, the epidemiology and the prevalence and incidence of NMOSD in Denmark. So in a way, it was even quite a follow-up of this cohort regarding the mortality.
You have a unique cohort to study and dive into this question. It's really well-defined, and you really encompass your entire healthcare system, which is, again, very unique, especially when we compare it to North America. And I also just wanted to touch on another point. This is truly a neurological emergency. We know that prompt treatment will offer these patients improved outcomes. We're talking vision, the ability to walk, control bowel and bladder. And then these patients need to get on appropriate therapy in the long run. And so, yeah, this is such an important point for folks to be aware of. We actually just put this into our neurological emergency resident education series because of these points you just mentioned.
Absolutely. This is a very important point.
Did you find it was treatment related? Are we seeing infections coming out versus the underlying disease?
Yes, so the cause of death was directly related to NMOSD in the majority of cases, in fact, in 93% of the cases. And 40% of the patients died due to attack or a combination of attack and infection. And with a median of 32 days following the onset of the attack, so very fast. And 1/4 of the patient had sepsis or severe viral upper airway infections. And we also found that if the patient had more severe first attacks or more attacks with poor recovery, then they had a higher risk of death. If the patients were more disabled during the disease course or at the last follow-up before death, that was also a serious issue. And we also found when we compared in the cohort those who deceased and those who did not, that the proportion of misdiagnosis for MS or even for other diseases was twice among the deceased cases. So this data really underlined the need for highly effective treatment approaches. We also investigated what was the relationship between the symptoms and the mortality, and it was quite interesting because we found that all patients who died had at least one longitudinally extensive transverse myelitis, and almost 50% of the patients who died had severe brainstem or cervical myelitis attack without recovery 6 months before death. And the last attack before death was myelitis in almost 50% of the cases, brainstem syndrome in about 1/4, and multifocal attacks in 1/5. So this really suggests that transverse myelitis, especially in the cervical area, and also brainstem syndrome are high-risk symptoms. And also we found one patient committed suicide because he was very much anxious, optic neuritis, and becoming blind.
Zsolt, were there any predictors of mortality in your cohort?
Yes, we examined that also, and we found that there were 3 factors which were very important predictors of mortality. And one was the age at disease onset, and it was an independent predictor of death. So older patients had higher risk of mortality and death. And the other two was the disability during the disease course and also the disability at the last visit. So these were the most important predictors of mortality and death.
So those are some really interesting findings there. What I'm hearing is that those more severe attacks, specifically those involving the brainstem and the spinal cord, seem to really be driving that mortality in patients. Do we know why that's the case? Do we think that there's autonomic dysfunction, or is there something else that's causing those patients to be at higher risk?
Of course, if a patient has cervical myelitis, these myelitis are usually longitudinal and extensive. And also the brainstem syndrome can cause very severe attacks and disability. Probably that's the reason why these patients have an increased risk of mortality.
And you also mentioned something on the misdiagnosis piece. What did you find there?
Yes, we found that when we compared those patients who were deceased and those who did not, then we found that the proportion of misdiagnosis for multiple and also for other diseases was about twice. That's why it's also very important to differentiate myelitis optica spectrum disorder for multiple sclerosis and even from other diseases, for example, MOG antibody associated disease.
And so those are patients that were originally diagnosed with something other than NMOSD that were later found to have the disease. Is that right?
Yes, exactly.
And how about, I know you mentioned infection, sepsis. How did you try to peel back those layers to see if it was related to the disease-modifying therapy for the NMOSD? Was it related to compromised status for those patients that was driving some of the mortality?
Yeah, unfortunately, the Danish population is small. Although we tried to examine also whether was there any connection with the treatment, we could not examine that. So the size of the population was too small because the patients were treated with different medications. So that's why it was difficult to assess, unfortunately.
But you did clearly see that a trend towards early correct diagnosis was really important for these patients.
Yes, absolutely. I think the early correct diagnosis is very important. Then the treatment of the attacks as fast as possible is also very important. And even the maintenance treatment to prevent the attacks is very important. And we should use very efficient treatment to prevent the attacks because the attacks are related to the disability and also to the mortality. That was very clear from our study.
Understandably, your cohort focused on a population of mostly European ancestry, but have you seen other series that looked at mortality and how race influences that?
Yes. Unfortunately, there were not so many cohorts with other population, but we know that also, for example, from our previous study, when we examined, it was also published in Neurology, when we examined the worldwide incidence and prevalence in a systematic review, that also showed that mortality and the disease severity is worse or higher in cohorts with predominantly African Black patients. And there was a UK cohort, it was published in 2012, and they also found that Afro-Caribbean patients had younger age at disease onset and more brain and multifocal attacks and higher of visual disability. So there was a Chinese cohort. It was published in 2021, which examined also mortality in the Chinese population. And they found that the median disease duration at the time of death was only 3.4 years. So it was much worse than our predominantly European population. And in the Chinese cohort, the most common cause of death was secondary infection, quite interestingly. And the second most common cause of death was extensive cervical myelitis, which we also found. And they also found other causes, for example, suicide. And there was a US cohort in 2018. They found also that the African ancestry constituted 41% of the clinic population, but 90% of the deceased NMOSD patients. And the average age of death in this cohort with African ancestry was actually, the average age at death was 52 years. So it shows that probably in patients with African ancestry, also maybe Asian population, like Chinese or Afro-Caribbean patients, the NMOSD is more severe and probably the mortality is also higher. Just to mention that we also examined what were actually the predictors of mortality. And we found that the age at disease onset was an independent predictor of death, and also the disability. For example, how disabled the patients were during the disease course, and also the disability just at the last examination. So these are also very important findings.
Some really important results there. And then I think some really humbling results on these non-white populations. So we've always known that AQP4 disease was more common in that group, but I don't think we've ever really understood if the disease was different based on race. And so I think more to come there. And then this trend of suicide, I think that was really surprising when I read your paper. What did your group think about that trend, especially since we've seen it across the literature?
Yes, so I think that's why it's very important to diagnose the patients early and treat the attacks as fast as possible and very efficiently, because the NMOSD attack can be very severe. And for example, if a patient has optic neuritis, then it may not recover well, and the patient can be blind. And this is the same also with myelitis. So the patient can be wheelchair bound very fast. We had patients who had severe repeated attacks, young patients, and became very much disabled just in 5 years. This is really an important issue, that once we start treating patients, we should not stop the treatment.
And we need to make sure our patients have access to the proper mental health resources, health psychiatry and psychiatry. And we're asking about those important factors to make sure that we don't overlook that element of care.
Absolutely. Absolutely.
So maybe we could end on how these results compare to other common neuroimmunological conditions like multiple sclerosis. Do we see the same trend?
Yes, this is a very good question because, for example, the symptoms overlap. With the symptoms of NMOSD, aquaporin 4 seropositive NMOSD. And we did. We actually compared in the Danish population the NMOSD severity and mortality to the mortality of multiple sclerosis. And we were very lucky because there was also a nationwide study published about mortality in the MS population, Danish MS population, between 1990 and 1999. In fact, the mortality of MS is much less. And also there was a Norwegian study when they examined the mortality in the MS population between 2000 to 2019. They also found that there is very much difference between mortality of multiple sclerosis and NMOSD, and the mortality is much higher in the NMOSD population. So that's why it's very important that very effective treatments are required. And luckily, we have now very efficient treatments.
I think that's a perfect way to conclude. Awareness around diagnosis and proper treatment for this really rare but devastating neurological disease. Zsolt, thanks for coming on to the podcast and sharing this work. Again, you can find the article in Neurology, Mortality of the Danish Nationwide AQP4 Seropositive NMOSD Patient Cohort. Zsolt, thanks again.
Thank you very much, Justin. It was a pleasure.
And for all of our listeners who want to learn more about neuroimmunological conditions, please join us in Atlanta for the AAN Summer Conference.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.